welcome to the module on the development of auditory function. My name is Ellen Thomas. I'm a speech-language pathologist and LSLS certified auditory verbal therapist at the University of Michigan. I am a salaried employee at the University of Michigan, and I'm a paid consultant with the Institute for Cochlear Implant Training. I am excited for the opportunity to talk to you about the development of auditory function. It is a key piece of what makes auditory verbal therapy different than traditional speech therapy. And it's important that we be able to explain to parents what that difference is, why what we do is different from just traditional speech therapy. So we'll talk about what auditory function is, the foundations of audition, and the levels of auditory function or listening hierarchies. So what is auditory function? Auditory function is the ability of the brain to use sound meaningfully. Auditory waves are converted into patterns of neural activity which are integrated with other sensory input, which from a survival standpoint may lead us to move. That's alerting. And at a more sophisticated level allows us to respond to music and to communicate with one another using spoken language. The importance of auditory function and the development of a functional auditory system is that this is the road to successful acquisition of listening, spoken language, and literacy. We now know that listening is a part of the development of good literacy. Let's talk about what the role of the LSLS, or the speech-language pathologist, on the cochlear implant team is in assessing auditory function. So audiological testing is a critical piece of determining cochlear implant candidacy. However, speech and language testing often reveals the individual's functional ability to use the signal meaningfully and sometimes can tip the scales in the determination of a borderline audiologic candidate. So we may be determining with young children that they are not developing a functional auditory system at all, or we may get into a more challenging situation where we have an older child and are asked whether or not this individual would be better off with a cochlear implant. This is an example of such a case, and it reminds us that auditory function, once it's developed, continues to require good access to sound through the doorway. This is an audiogram for a 13-year-old who had a progressive sensorineural hearing loss, and this is the aided audiogram, so the best aided condition, and we can see that it's far from optimal. And this individual did meet candidacy at +5 dB signal-to-noise ratio. But even more telling were the scores for auditory comprehension or oral comprehension. In December of 2019, the standard score was 77, so a moderate delay, with an age equivalency of 8 years, 5 months. And then the reading scores were a standard score of 104 and an age equivalency of 15 years, 2 months, which was in the average range. Now, it's very unusual that you would have somebody to have such a high score, or, solidly in the normal range on reading, and then come back with such a low score for auditory comprehension. Well, this was indeed a red flag that the access to sound was not adequate for this individual to perform optimally. The scores on the right are 6 months post-op, and we see that now the auditory comprehension standard score is 110, and it happens to match the reading comprehension score of 110. So with 6 months of device use, this child improved by 15 years, 7 months in their auditory comprehension scores. That's the power of access. Those neural pathways were there, but access had been lost. And you see here just a follow-up email from the patient's mother that's thanking the audiologist for helping them and for the team for encouraging them to move forward with an implant. Hearing is the primary sense. Listening is the primary modality for learning spoken language. And if you don't have good listening, you're not going to have good spoken language. We often need to counsel patients about what it takes to become a good listening and spoken language user, and therefore the reasons why an auditory verbal approach is a great first option for most children in that birth to 3 range that are going through cochlear implant candidacy. For one thing, universal newborn hearing screening provides us with the opportunity to take advantage of that powerful critical period of learning language, when the neuroplasticity is greatest and it's the easiest. There's also the fact that 90 to 95% of children who are born deaf are born to hearing parents who communicate using listening and spoken language. We know that learning a second language takes years if you want to become fluent. And this is no different if we're talking about a parent who's hearing and communicates with spoken language, learning a manual language such as American Sign Language, than it is if we're talking about that parent learning a second foreign language like Japanese. So we know parents are the primary teachers of their children. They have the biggest influence, and the majority of parents communicate using listening and spoken language. So they already know listening and spoken language. What they don't know is how to best help their child develop the same ability. But babies are what Pat Kuhl refers to as citizens of the world. They are able to pick up any language. Whatever surrounds them that they have access to, they will pick up. Whereas as adults, we're language bound. So for the baby, this is a great time for them to learn language. And for the adults, it's not a good time to learn language, but they can be very motivated to learn strategies and things that will help their child develop. Babies don't learn from television. They need to be surrounded by live people using spoken language. Or if you wanted them to be fluent in American Sign Language, they would need to be surrounded by people using American Sign Language. So we need to look at what is the environment and what is the road that for the parents to get what they want and to be successful. Let's think about when an auditory verbal approach is a good choice. You see here the 5 most common communication options listed up here, and they've all been around for a long time. None of them started yesterday. So an auditory verbal approach is a good first choice when there's early identification of hearing loss, when the potential for good access to the speech spectrum of sound is present with technology, even if maybe it's delayed till they're able to get an implant, if there's good parental involvement. Now that could be said of all the options. It's always a better choice if there's good parental involvement. If there is a vision impairment present, such as individuals diagnosed with Usher syndrome, then the ability to listen and be able to communicate through listening and spoken language becomes very critical, as opposed to having to rely on vision. There are also many children with cerebral palsy who may not have the manual dexterity to be good signers, but they can listen. And even if in some cases they can't speak well, if their motor control is not good for spoken language, with the help of an implant, they can almost always become very good listeners. And then we can help develop an alternative language output through augmentative communication. Another reason that parents might choose an auditory verbal approach is because we have outcome data that shows its efficacy and good outcomes, strong outcomes for children who are deaf or hard of hearing that received access to sound in early childhood. I'm going to review with you just briefly a study that we did in our facility where we divided patients into 3 groups. An auditory verbal group where the family attended at least 25 therapy sessions with an LSLS certified AVT during the first year following cochlear implantation. The oral group, where the child's mode of communication was spoken language with no sign support, and they had not received, at least in the first year, auditory verbal therapy. The third group was the total communication group, in which the child used a combination of spoken and signed language. And I found recently that this has become something that a lot of parents are interested in, with the idea that's emerged that American Sign Language is a deaf child's native language, and therefore parents are feeling like that ought to be part of what they are doing. They need to understand that most families, children, can't get good outcomes in both when they're doing them simultaneously. And that if we want listening and spoken language, we have to develop those neural pathways in early childhood, or our outcomes are going to be definitely impaired and possibly poor. When we looked at receptive vocabulary and reading comprehension in the three groups, you see that the auditory verbal group in green, starting at year 2 of device use, which means if they were implanted around a year of age, they were now 3, through year 7 of device use, started in the normal range, and the normal range was maintained, with the patients averaging right around the mean of 100 across time. The oral group started at a standard score of 74, which would place them in a moderate delay, and at 7 years of device use, were finishing up with a mild delay, borderline moderate, with a standard score of 80 on average. Our total communication group started with a profound delay at a standard score of 52, and across time, with 7 years of device use, we're finishing up with a standard score of 61, indicating that their receptive vocabulary was still severely delayed. Then, if we look at reading, we see that the same pattern held true, where the auditory verbal group was performing better than the other two groups, and the total communication group was struggling the most with reading. The auditory verbal group started and maintained standard scores in the normal range from year 3 to year 7 of device use. The oral group started with a standard score of 103, so with early literacy was doing well, but across time they dropped slightly, still in the normal range with a standard score of 91. Our total communication group started at a borderline normal range with a standard score of 85, but across time dropped to a standard score of 70 as reading became more complicated and required the ability to sound out words. So a standard score of 70 is placing them with a moderate, almost severe delay after 7 years of device use. The difference between groups was significant for all tests we gave: the Peabody Picture Vocabulary, the Expressive Vocabulary Test, the Woodcock-Johnson Passage Comprehension subtest, and percent consonants correct, which is a measure of articulation. So the auditory verbal group performed significantly better than the other two groups for all measures at all intervals. A linear mix model analysis was used to minimize the effects of different age of implant on scores, because very naturally children who were implanted later tended to be more likely to be using total communication. I mean, you certainly hope that you don't go for years and years with nothing, but even when we factored this in, the significant difference held true. So it's important to know when an auditory verbal approach is a great first option, and also important to know when it's not a good option. And certainly if there's very late identification of the hearing loss, we know that this critical language learning window does close, and generally it's considered to be birth to 5, but certainly by age 7. If the child has not developed those auditory pathways, we need to be looking at some other option for communication. In our clinic, the group that often fits this are children who were adopted from a foreign country and not identified as hearing impaired until they got to this country. Another group that's not a good fit is when there's poor potential for good access to the speech spectrum of sound with technology. Okay, if there's no eighth nerve, it is not the right approach. And if there's eighth nerve deficiency, it may not be the right approach, and we might not want to put all our eggs in one basket. We know that technology only works if you use it. So if a family starts in an auditory verbal approach and there is a clear pattern of minimal use of hearing technology, we know we're not going to be successful. And it's time for a conversation. Sometimes this conversation turns things around and then we can continue. But sometimes it's just not in the ability of the family to make this happen. And if technology is not going to be used consistently and that access is not going to be there to keep that doorway open, then we need to look at another approach. Low parental involvement is a red flag for all communication approaches, and auditory verbal is no different. But if you see that a parent is really not vested, then the auditory verbal approach is probably not the best choice. If they simply cannot, at this point in their life, give the time, give the energy, then we probably want to look at a different approach, maybe an auditory oral approach. And another time where the auditory verbal approach might not be the best first choice is if the parent's native language is American Sign Language. They are providing a rich language that they're fluent in their home, and we need to look at what are our best options, and if the family does want an auditory verbal approach, how are we going to make that happen? I've seen a lot of misrepresentation of the bilingual advantage, both in writing and in people talking, when they're talking about bilingualism of spoken English and American Sign Language. We know that a growing number of studies have reported advantages in nonverbal executive control tasks for bilingual children. These results trace the bilingual advantage in cognitive control to the unimodal bilingual's experience in controlling two languages in the same modality. So people who have researched and really uncovered this bilingual advantage have done so talking about two spoken languages, not languages that are two different modalities where one is signed and one is spoken. But I have seen this often misquoted in articles. Our past has shown us that when a child has a significant hearing loss, doorway problem, learning to listen and talk doesn't happen well without intervention. So what is the auditory verbal approach and what makes it successful? The auditory verbal approach is an early intervention approach grounded in 10 guiding principles. And these principles all need to be in place if you're going to get a successful outcome. And when something's not going well, you can often go back to the principles and find where something has gone awry. The auditory verbal approach takes advantage of the brain's neuroplasticity in the first few years of life, today's technology, and the power of the parents. The first work of the auditory verbal practice is building a functional auditory system, or auditory function. The tasks of auditory function are to pick up a signal, to change it to neural responses, to send the signal to the correct areas of the brain, and to process the signal meaningfully and respond as needed. And I'm going to show you an example of this in a very early listener. This little girl is not quite 6 months post bilateral cochlear implantation, and we're going to see that she is developing an auditory feedback loop.
Hi. Say hi. 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 Hi.
So she was able to pick up the signal, change it into neural responses, send the signal to the correct areas of the brain, and process the signal meaningfully and respond appropriately. A functional auditory system in the 21st century also includes talking to tech. And here's an example where we see that the child is able to talk to the tech, to understand what's said back, and to convey a message back to his parents.
Hey Google, what's the weather today?
In Pittsfield Charter Township today, it will be partly cloudy with a forecasted high of 13 and a low of 1. It's currently 7 and cloudy.
It's cloudy!
So he certainly got that it was cloudy. He might not have gotten everything, but he understood that it was cloudy and he was able to convey that enthusiastically back to his parents. We've talked about auditory function. Now let's talk about the foundations of audition and revisit some of the very important points that Dr. Flexer made in her module. Where does it start? The earways are the doorway to the brain. Babies with hearing loss become delayed. Hearing loss is a neural developmental emergency, and we need to think of it as such. Time is critical. Did you know that children as young as 4 days old can distinguish the vowel sounds of the language in their natural environment from those of a foreign language? At 4 days of age. These babies with typical hearing have been listening since about 20 weeks gestation. So our clientele who have likely not heard are already behind at birth. But this is a powerful time, early childhood. Let's use it to our advantage. More than 1 million neural connections form per second in the first few years of life. Let's harness that strength. We've got a great boon to what we do in the US anyway, with FDA guidelines lowering the minimum age for cochlear implantation to 9 months. That can only help us harness this neural plasticity of the very young child. In order to be a good auditory verbal practitioner, you have to know and understand the principles of auditory verbal practice. These are the grounding factors that lead to success. When we follow the principles, we will be much more likely to have a very successful outcome. And when things are going astray, we can often go back to the principles and find out that we're not adhering to all of them. And that tells us where we might need to change something. Principles 1 and 2 of auditory verbal practice are: 1, to promote early diagnosis of hearing loss in newborns, infants, toddlers, and young children, followed by immediate audiological management and auditory verbal therapy. Principle 2 is to recommend immediate assessment and use of appropriate state-of-the-art hearing technology to obtain maximum benefits of auditory stimulation. These principles align very well with the EDI, or Early Hearing Detection and Intervention, 136 plan. This plan recommends screening by 1 month, diagnosis, so understanding the type and degree of hearing loss, by 3 months, and intervention by 6 months. These goals are now often being reconsidered as perhaps needing to be the 136-week plan. You talk how you hear. Young children will speak how their parents speak. So if their parents are speaking English with a foreign accent, the children will too, until they get into school where they're surrounded by peers that are speaking the regional American English dialect. If your auditory input is poor, your speech will be too. Muddy in is going to equal muddy out. So the effects of hearing loss on speech creates the characteristics, if it's not managed, of, quote, deaf speech. So speech tends to be monotone. There tends to be a cul-de-sac resonance where it's very back in the oral cavity. There are errors of articulation and nasality. And these cause the layperson to realize something is not quite typical. This is a video clip of a lovely young woman who is a native ASL user, and you'll see that the auditory feedback loop has not had the opportunity to really develop, and she really struggles to imitate words.
No way. Yeah, she's singing, you're right. Can you say apple? Yeah, use your voice. Say apple. Yeah. You're gonna eat the fish? You? What? It's not ready to eat. Fish. Mhm. Yeah. Tree. Tree. Uh-huh.
So although this child has good detection with her cochlear implant, the neural connections did not get made that are necessary to give her the ability to repeat what she hears well. You talk how you hear. Typically, developing babies with normal hearing will develop the vowels of the language they hear easily. Infants born with severe to profound hearing loss often vocalize an inhalation, they often have an ear-piercing shriek, and they'll not develop the full repertoire of vowels. And even those who become proficient listening and spoken language users after a cochlear implant often fall in a 0 to 3 month range when we're measuring the development of listening and spoken language prior to cochlear implantation. This is a video clip of Dina at 5 months. Dina has a profound sensory neural hearing loss bilaterally, and she is aided at this time, but because of her age has not yet received a cochlear implant.
Dina, say hi.
Say hi, Dina. Hi.
Ah, there's the airplane. Yeah. Right. Ah. Yes, that's right. Here comes the car. Yeah. That's the car. Yeah.
So although she doesn't have optimal access to sound, this video clip does show us some of the value in pre-op therapy for a child with a profound sensory neural hearing loss. She's learning the turn-taking, serve, and return type behavior, and we have the opportunity to coach the parent and teach her things like moving closer to the ear is helpful. So this time, although there's not optimal sound, can still be really, really valuable in setting the stage to a successful outcome. Principles 3 and 4 of auditory verbal practice. Principle 3 is to guide and coach parents to help their child use hearing as the primary sensory modality in developing listening and spoken language. Principle 4 is to guide and coach parents to become the primary facilitators of their child's listening and spoken language development through active and consistent participation in individualized auditory verbal therapy. Parents and caregivers are the architects of early brain development. But do they know that? One of our roles is to discuss and determine expectations, to talk about where the bar is set. What do they want to see? How would they like their child to be talking in 5 years, in 10 years, in 25 years? It's our job to talk about what it takes to get to where they would like to set the bar. We want to teach, coach, cheer, listen, and facilitate full-time device use, because none of it can happen if we don't get good use of the technology. We want to help parents think eyes open, technology on. And we want to encourage them that this is a front-end loaded process, that it is intense now, but that there is a payoff for a lifetime, and there is no way to measure what might have been. Principle 4 has gotten a real boost from telepractice. Active, consistent participation in individualized therapy. For many parents, teletherapy has opened the door to being able to participate consistently in individualized therapy. And we've done studies now, and we know that this type of intervention works. When we're talking about expectations, and Especially if things aren't going quite like we wish they were, we can talk about Henry Ford's quote, "If you always do what you've always done, you'll always get what you've always got." Are they seeing the progress they would like to see in their child? If not, what can we do differently? What might it take to get there? One of the expectations that parents have for their children most of the time is that their child will sit in a car seat. In early childhood, riding in a car seat is important to ensure a child's safety. Most children are resistant to sitting in a car seat at some point, and most parents enforce sitting in a car seat without exception. For some reason, it's different with hearing technology. It probably goes back to the fact that hearing loss is invisible. In early childhood, we know that the use of hearing technology is important, is critical to ensuring a child develops listening and spoken language, and that most children will resist wearing hearing technology at some point. But many parents make exceptions to enforcing the wearing of hearing technology. This, for some reason, does not become a non-negotiable issue, and therefore intermittent use often persists. We have to ask ourselves, do parents understand when the hearing technology comes off that they are removing brain access devices? Do they understand the potential cost to the child's educational and vocational professional future? So as frustrating as it is to keep devices on little children, we need to encourage parents to make this a non-negotiable thing. The sooner that the child understands this, the sooner they'll have an end to the constant taking off and putting on of hearing technology. At the same time that we're pushing for enforcing this, we also have to have some compassion and empathy for the job that they have to do, because dealing with a toddler who wants to do anything that we don't want them to do is exhausting. So we want to keep reiterating why it's important and shoot for a goal of 10 hours a day of use.